use ultrasound to assess the patients with PTS. We use venography, venous plethysmography, physiological venous function tests, and ambulatory venous pressure monitoring, and not to measure the ankle brachial index in these patients. Ultrasonography is a mandatory test in examination of patients suffering from PTS. We use ultrasound to assess the deep venous anatomic abnormalities, either acute deep venous thrombosis or following up the different evolutions of this thrombus. Here's an ultrasound image showing the vein is distended by acute thrombosis with loss of compressibility, occlusive thrombus. Here's a non-occlusive thrombus showing flow around the acute thrombus within the vein. In rare cases, there is total resolution of the thrombus, leaving small venous thickening or intravenous small web, but it's a very rare case. Most commonly, we find subtotal resolution of the thrombus, leaving thick intravenous webs, or even echogenic fibrillary within this web. In many cases, we find non-recanalization of the thrombus, leading to total occlusion of the venous lumen by chronic fibrotic thrombi. We assess the deep venous hemodynamic abnormalities as reflux or complete obstruction, or even focal luminal stenosis. Here's an ultrasound image showing partial recanalization of the popliteal vein with reflux within. The spectral analysis waveform showing the reflux is more than 2 seconds. Also, we can detect an obstruction by measuring the flow in the iliac vein. Normally, on the left side of the screen, you can see preserved phasic flow within the vein, with loss of the phasic flow denoting proximal obstruction, as on the image on the right side of the screen. Also, we can detect stenosis. As you can see on the left side of the screen, there is marked increase in the velocity inside the vein. Also, we examine the superficial and perforating vein. Most common finding in patients with deep venous disease that you have a dilated superficial veins in the thigh and the abdomen, but with no reflux. You have to be sure there is no reflux, because it's a normal finding as these veins act as a corrector. So if you are not accurate in detecting reflux, the patient will do any procedure and he lost his collateral. So it's common to find a dilated vein, but with no reflux superficial veins. Also, we detect leg incompetent perforators. As we can see here, there is a flux within the perforator. We also assess the suprainguinal obstruction as iliac fibrotic obstruction or external compression as in May-Turner syndrome, other causes as tumors, retroperitoneal fibrosis, and very rare we can detect inferior vena cava atresia. Here's an ultrasound image showing total obstructions of the external iliac vein by fibrotic thrombi. Also, we can see here on the left side of the screen, compression by the common iliac artery on the vein, May-Turner syndrome. The most important issue in our duplex study is to detect infrainguinal abnormalities, either combination of superficial and deep venous reflux, which is common, and combination of refluxing and popliteal or femoral venous obstruction. So our role is to detect which one is the predominant, the obstruction or the refluxing, to help tackling for treatment of the patient. We examine the great saphenous vein during exercise. If there is reflux and the reflux is exaggerated, so we have a proximal obstruction at the iliac level, or examination of the deep veins after compression on the great saphenous vein. If the flow inside within the deep veins increases, denoting that there is a refluxing type and there is no obstruction. So we have to surely differentiate between these two pathologies for patient treatment sake. Venography. I'm talking about the CT and MR venography. CT venography, we can do it by either indirect, injecting the contrast in the arm vein, or direct by injecting the contrast media in the foot vein. We detect extrinsic compression, we detect stent patency, or also we can detect a concomitant PE in the patients. Here image showing external indentation on the right external iliac common iliac vein, total occlusion of the left internal iliac vein, and we can assess the stent only in axial views, because if you do a reconstruction, as you can see on the right side of the image, the lumen is totally concealed by the stent, so you have to assess it in axial views only. MR venography is the gold standard in studying the venous pathology, especially in the abdomen and pelvis. We have a flow-dependent MRI, flow-independent MRI, and contrast-enhanced MRV. We have different sequences as gradient recalled echo and time of flight. And the flow-independent MRV, we have the most important balanced steady-state free precision MRV, which detect very accurately the intralumen structures within the vein, especially in the pelvis and the cava. The most accurate one is the contrast-enhanced MRV. You can see here in this patient, we have in the image B indentation by on the common iliac vein, May Turner, and you can see here there is a DVT in the lower image in the popliteal vein. Direct contrast venography is very rarely used and may be used if we are planning to intervention. We can also do venous plethysmography as air plethysmography, photoplethysmography, and outflow plethysmography. Here is the outflow plethysmography, and this very accurate detection on the outflow obstruction. Also, we can perform a physiological venous function test as venous refilling time, maximum venous outflow, or calf muscle pump ejection fraction. Finally, we must do an ankle brachial index to every patient suffering from venous ulcer to exclude any arterial disease. It's a very crucial point to assess. Here's the algorithm of patients coming to us suffering from venous ulcer related to the PTS. Finally, if we are doing an ultrasound examination of the veins, we must our data must be depicted on a venous map regarding that's the occlusion, as you can see, iliac, or the refluxing flow you see in popliteal, infrapopliteal, and or the normal flow in the great saphenous vein. Thank you for your attention.